I'm happy to welcome our moderators and judges for this afternoon. We have Dr. Kurian George with us. He is a professor of community medicine here at CMC Velo. I kindly welcome you to come forward to the desk, sir. We also have with us Dr. Prabir Kumar Chatterjee. He's a community physician at Amadar Hospital in Bankura, West Bengal. I kindly request you, sir, to join the moderators. I now hand over to the moderators to start the sessions. I call our first presenter forward, Dr. Meena Putturaj, who will be presenting on patients' rights for health equity, a critical discourse analysis of the rhetoric and reality.
Thank you very much for this opportunity to share a piece of work from my PhD on patient rights. So my presentation is titled Patient Rights for Health Equity, a critical discourse analysis of rhetoric and reality. So in this conference, we are talking about how to solve health inequities. So in that sense, the rights framework can be considered as a useful resource or act as an instrument to achieve health equity and also social justice. So the moment I say patient rights, these are the things comes to your mind. It is the list of, I can't see the slides here. Yeah. So the moment when we hear the term patient rights, what comes to our mind is the patient rights charter with a list of rights like right to information, right to dignity, so on and so forth. Next slide. I can't. So where this idea of patient rights comes from, it is basically application of human rights principles in the area of healthcare context. In other words, we can say these are the rights that are attributed to healthcare seeking individuals. And in India, we have our constitution. In the constitution, the human rights framework is endorsed. And we are also part of international human rights frameworks and treaties. So it basically flows from there. If you see the literature on patient rights, there are a lot of literature on patient rights, especially the governance aspect of patient rights in high income countries, especially in the European context. But when it comes to low and middle income countries, the literature, the scholarly work is very limited. And the literature that is available in India mostly focuses on whether doctors are aware about patient rights, whether nurses are aware about patient rights, whether patients are aware about patient rights. But then given the gravity of the problems that are reported in the media and also in the empirical studies, which talks about disrespectful care, discriminatory care, denial of care. So considering that, we really don't have much idea about what are the governance, the larger structural issues that affects the implementation of patient rights in hospitals. This is missing in India. So basically, when we think about patient rights, we should think about the governance that governs the behavior of the healthcare providers and the patients, and also the system and the patients. Because when the patient approaches the health system or to the hospital, there's a huge power dynamics that is at play. There's a huge power differential that is at play. Usually the patient, be it rich or educated, usually the patients are at a disadvantaged position because of the various factors that is displayed here. So basically, if you want to think about the structural issues for implementing patient rights, we need to get the governance right. By governance, I mean, conceptually, I mean, it is about the power relationship among the actors. Because ultimately, this power relationship should be meaningful and it should be fair for both the healthcare system as well as for the patient. So my main research question is that I'm trying to understand the idea of governance through language, through discourse, how it is actually, the idea of patient rights is thought about, how it is conceptually understood by the people, by the stakeholders that are concerned for implementing patient rights, who says what, and thus about patient rights implementation in health facilities and why do they do so. So the methodology was, it is a qualitative research and I adopted a critical research paradigm. By critical, I mean, we are trying to question the underlying assumptions of our practices, our way of thinking. We are really going into the, diving deep into the assumptions of our way of thinking and acting. So that is critical research paradigm. So basically, I'm trying to understand the language that is used in everyday conversation between the healthcare providers and the patients, and not just in the talking, but also in the text that is used in the hospital about patient rights, and also the practices concerning dissemination of patient rights ideas to patients, care-seeking individuals, and their family members. So this particular study was conducted in Mysuru district in the state of Karnataka in 10 both public and private health facilities. We used a variety of data sources. We conducted interviews with different cadres of healthcare workers, doctors, nurses, technicians, so on and so forth, patients, their family members, even the state health officials, district health officials, so and also civil society organization representatives. So we conducted in-depth interviews. We also organized focus group discussions, and we also analyzed a lot of documents concerning patient rights provisions. For example, we have subnational level policies. We have particular legislations which have patient rights provisions. So we try to read in between the lines, try to understand the assumptions behind these policies. And also we analyzed the syllabus of medical and nursing profession concerning patient rights. And also we used the patient rights charter that were displayed in the health facilities, posters. So we also took cues, data from those that were there in the public domain of the health facilities. So when we analyzed using this critical lens, we found that the idea of patient rights is reduced. It's not actually emanating from human rights framework, even though we say our constitution has fundamental rights, we have endorsed human rights, but that is not actually reflecting or translated at the subnational levels till the health facility. So the idea of patient rights is rooted in economic, consumerist, and quality of care logic, not necessarily from human rights framework. And also the idea of rights, patient rights was reduced as a matter of availing some grievance redressal, or it is both care providers and also patients equated patient rights with availing some specific schemes from the government. So there was not, they were reducing this idea of patient rights to these things. And also in the health facilities, what we observed was that there were tokenistic approaches to actually promote this idea of patient rights. For example, patient rights charter are hung in one corner where it is not actually visible for the patients. There were patient rights brochures were there, but those pamphlets and brochures were not actively disseminated to the people. So people have to discover the idea of rights, learn about the idea of rights themselves. And the other important discourse that was prominent, especially among the healthcare providers and the health authorities, was that if we promote this idea of patient rights among the care-seeking individuals, it might, especially in resource-limited settings, it might lead to violence against healthcare providers. So it is not just in the thinking, but sometimes it is also shown in the action. For instance, you see this patient record, template of the patient record, which shows that even though the hospital had patient rights charter, patient rights are not printed in the record, but only the responsibilities are printed. So symbolically, indirectly, you're trying to emphasize something over the other. So, but then we should also try to understand why this kind of ideas exist about patient rights on the ground. We all know that since 1990s, our Indian health system, our Indian economic policies have ascribed to this kind of thinking called neoliberalism. So in this kind of environment, these kind of ideas, the ideas about patient rights, a specific idea about patient rights thrives. For example, in neoliberal healthcare context, healthcare is seen as a commodity that can be purchased in the market. So in that sense, people tend to think, oh, patient rights are for the people who have money. So it is treated not as a necessity, not as a human rights, but it is treated like a commodity that can be purchased. If you have, it is a luxury. It is treated like that. And also the other important thing in neoliberal health context, what happens? The social sectors such as education and health suffers. So when there are poor resources, even the care providers find it very challenging to implement, to realize patient rights in everyday practice. And in the neoliberal health context, the citizen becomes a consumer. So patient rights becomes consumer rights. And also the individual responsibility is more in a neoliberal health context. That is why they have to mobilize resources on their own to access healthcare. In that line, even the idea of patient rights, it is your responsibility to learn and discover about patient rights and also to claim your rights. So the state is taking a backseat, not actively promoting this idea of patient rights, not articulating explicitly the idea of patient rights to the care-seeking population. So these are, in this context, these kind of ideas prevail. So the main implications of the findings is that so the current discourses, what we have about patient rights is actually restricting the agency of care providers and care-seeking individuals. And we need to create more disruptive dialogue spaces. We need to talk more about it. We need to have explicit statements, text in our everyday conversation, and also in our social practices. For example, we need to infuse more of human rights into the health professional curriculum. So this is a small poem which I wrote after coming back from a field work about patient rights. I don't know if I have time for this, but that is there for the display. Thank you so much for this opportunity.
Thank you, Meena. I would like to ask, probably, do you have any questions before we hand over to the audience?
No, hand over to the
Questions from the audience? We have just time for a couple of questions. Thank you. If there are no further questions, we can go on to the next presentation.
Thank you so much.
Our next presenter is Dr. Rehna Mohamed, presenting on reviewing equity considerations in states' response to COVID-19 through theoretical lens.
Respected jury members, other fellow presenters, and all like-minded people vouching for equity present here, a very warm good afternoon to you all. Today, I'm presenting a theoretical paper on equity consideration in states' response to COVID-19. Quickly laying the background. As you'll know, COVID-19, the pandemic of century, had struck the whole world equally. However, the impact of the consequences have felt differentially, affecting the have-nots, the poor, the marginalized, the vulnerable, more in comparison to their counterparts. When fair, even-handed, just opportunity to attain highest maximum is not available for many, they are being prevented from reaching their highest potential. Thus, the aim of the study was to develop a viewpoint on the equity consideration by the state in its responses to the pandemic through a theoretical perspective. It was an exploratory method. 2 public health measures, lockdown and vaccination drive, were studied, narrative literature review, understanding the basic tenets of the justice theories, applying critically, understanding the equity consideration in the state responses. Why the theories of justice? The oft-repeated image, equality, it is about equal share of things. It is assuming that everyone benefits from the same support. In equity, it is providing as per the need. Providing as per the need so that the outcomes are made equal. Coming to justice, it is removing the fundamental barriers that has led to inequality in the first place. So when justice is not met, we'll have to take the middle position of equity so as to counteract the situational differences. So this is a quick look through a word cloud on justice. It is considered as the most important virtue by Plato in his book Republic. The guardian, the protector of the marginalized, the most vulnerable. Here I've attempted to classify the theories of justice as moral and social. Moral, it is more based on the virtue, based on what is right and wrong. And the social justice, it is based majorly on 4 major principles, which include distribution, rights, access, and participation. So we can see the theory of justice has come a long way from being the Thrasymachine idea of the right of the strong to the most disadvantaged. So here we are going to quickly look through the justice theories and understand the underlying political philosophies and extend it to the inequity in the situations of lockdown and vaccination. So just enlisting the equity issues identified, the vaccination drive and lockdown. I'm quickly rushing through the slide. Now the theories, we are reading the deontological and consequential theory, the 2 moral justice theories together. When deontology, it talks where end does not justify the means, consequential theory, end can justify means. So the declaration of lockdown, if it has reduced the number of mortality rate due to COVID spread, it is considered it can be justified in spite of the fact that there had been deaths due to hunger or due to a lack of access to medical care. So this is where equity is violated when you talk in the consequential line, and in deontology, you can see how it underlines inequity when the end does not justify the means. Coming to the libertarian, here there is nothing more sacred than freedom of the individuals. So reduction in mortality rate due to lockdown cannot justify the loss of freedom. So here it's a market that rules. It is the market that decides, and state plays a very minimalist role. So in vaccination drive, you can see that in a situation in India, when India had given 50% of procurement of vaccine towards the private sector and had seen that vaccine has been not affordable for the marginalized people, and a rectification was being done when the government pitches in and takes a 75% share. So that is where we get into the next theory of liberal egalitarianism or Rawls' theory of justice. So it's about rationality, it's about reasonableness, it is about principled liberty and equality. So you have freedom, but the state, the emphasis is given to how the state has to intervene. State is no more minimalist here. State has to intervene, and it should be in advantage or the worse off. So now the question is, how far has the state fared in taking care of the basic provisions of the people during the lockdown or during the pandemic as such? And is the provisioning of just the basic primary social goods enough? This is where we go to the capability theory by Sen Nussbaum. So here, it is not about the primary social goods. It's about the capabilities that is being given to the individual. Talks about the individual differences. It talks about how it is important to think about what the person is and can be and can do. It is about understanding the basal equality and the human diversity. More than the process or the outcome, it is the capability to achieve the outcome that is being considered here. Now, how far can the capabilities of an individual help in tiding off a situation like pandemic is again questionable. Maybe we can, here's what maybe the communitarian theory or a collective theory would be handy, which talks about pluralism, complex equality, about different distribution for different social goods. It takes care of heterogeneity. It focuses the differences in the population. So when the vaccination drive is made digitally, digitally accessible, the government should ensure that there is realize that there is a group of people who are digitally illiterate. There is a digital gap. Understanding the plurality, understanding the heterogeneity of the population, and working towards that with the community, and understanding the heterogeneity becomes important. So now we're extending it a bit further. We are clubbing the Sen Nussbaum capability approach of individuals to the collective. So why not the capability or the functioning become collective to the giving it to the population as a whole, understanding the heterogeneity, focusing on the diversity. Like we have models like Kerala Community Kitchen and Meghalaya Mutual Aid. So to conclude, pandemic has made obvious the fault lines. The deeper illness is seen, which is social and political. So there is not a single theory that can translate in explaining the inequity that has happened. Maybe you can start with the Kantian categorical imperative or reflexive equilibrium as a moral guide. And you can say that the state can never remain minimalist. State has to intervene by the Rawls theory of justice. The state has to intervene, and state should intervene, not remain minimalist. And that the capability and the approach, the capability should be of the collectives, making a collective approach so that the plurality and heterogeneity is understood. Thank you.
Thank you, Rehna. Any questions from the audience? Any questions or comments?
Thank you, Rehna. This philosophical speech is very close to my heart. So I was wondering, philosophy is too difficult to understand for a normal person. But to policymakers, if you see, the most common philosophical approach has been this utilitarianism, the greatest amount of good for the greatest number of people. What do you think about it? How do we orient our policy community towards other ideas of justice? Because the utilitarian approach is quite very straightforward, very easy. You don't have to break your head so much. But how do you sensitize our policy community towards other theories of justice?
So this is where, so situation like a pandemic is exactly what can explain what is remaining as a fault line, and where you understand that how the libertarian or the utilitarian theories cannot explain a situation like pandemic, when the state cannot remain minimalist and state has to work. And also, I think, so currently, our policies are more on an evidence-based, it is going on an evidence-based manner. And we have health technology assessment hubs, resource hubs, which works in understanding the cost and the benefit involved in each of the program. So there again, you have the utility, the benefit that is being measured is in terms of utilities. So there is an effort which is being done so as to include equity into it and give a weightage on equity. So even from the policymaker side, this has come, and equity is considered as one of the major pillars in decision making, in bringing about the health technology assessment reports during the dissemination. I think that is in a good line. I mean, it is for a good change, and I think that is where the future should go, and how the policymakers as well should look forward. Thank you.
If there are no further questions, can we go on to the next presentation, please?
Our next presenter is Dr. Varsha Sridhar, presenting on wastewater surveillance for equitable mapping of local epidemiology of bacterial antimicrobial resistance patterns.
Thank you so much. Thank you for the invitation. I'm really privileged to be here. Can you hear me? Is this audible? Great. Thank you. I'm wearing two hats. I'm coming here as the co-founder of a company called Molecular Solutions, as well as the co-lead of a coalition called the Precision Pandemic Health Initiative. I hope by the end of this talk, you will recall the links between slums, sanitations, and antimicrobial resistance. I would like to be able to persuade you that wastewater surveillance is a fantastic way of getting community-level hyper-local data. I hope I also leave you with an appreciation for the need for consortia for tackling wicked and complex problems like antimicrobial resistance. And I hope you'll reach out to me for collaborations and partnerships. I'm not going to go into this. I've already talked about that. Let me just give you a little bit of a context to my work. When we started my company in 2017, we were mostly focused on innovation and R&D on viral resistance and diagnostics for viral resistance. When COVID came, like so many of us, we also went through a change in perspectives and thinking, and we switched to large-scale diagnostics. We actually first started off with collaborating with Karuna Trust to set up Bangalore's first COVID testing center in a primary healthcare center. And then that gave us the opportunity to scale very, very large and very fast. And we were very naive. But at the same time, we were also able to set up Asia's largest real-time hybrid citywide wastewater-based surveillance for COVID. I'm just going to tell you a little bit about what the context to all of this is. All of us, whichever part of the country we come from, whether we call our sewages nalas or moris or shakadais or whatever, we've all seen sewage by the side of our streets. In Bangalore, depending on where you're from, either 50% to 80% of the sewage tends to be above ground. That while we have good STPs or sewage treatment plants and underground drainages in some parts of the city. Depending on where in the city you are, there's a good amount of it which is also above ground. And as you can imagine, there are a lot of slums that live fairly close by to these open drains. And these slum dwellers, of course, are at a close proximity. They're at higher risk for infections that are carried by sewage. They're also at closer proximity to livestock. And because they have, as we all have heard multiple times, they're at significantly lower access to timely healthcare, and they're also at higher access to taking inappropriate antibiotics. So there is a large population at very high risk for antimicrobial resistance. Sewage also tends to be an amazing place from a molecular biologist perspective. It's an amazing place for antimicrobial resistance transmission, but obviously from pretty much every other perspective, it is a bad thing. One of the problems with sewages, with slums is that if they are non-notified, and 66% of slums in Karnataka are non-notified, they basically have very little recourse to normal rights like access to toilets or water. So vulnerable populations just continue to stay vulnerable. This is kind of where the wastewater surveillance sort of came in. The wastewater surveillance in Bangalore is now, it's completed over 2 years. We recently celebrated 2 years a few months ago. And what we basically felt was that a lot of national guidelines on not just antimicrobial resistance, but pretty much every disease comes from a very, very small population. If you have a community of 1,000 people, a fraction of that ends up in a tertiary care center where that data is actually used for national guidelines. Whereas a wastewater sort of dipsticking might be able to give you a better sense of what the community is actually undergoing at that particular point of time. What most routine AMR guidelines miss are, of course, marginalized populations. They also miss community level AMR because you almost invariably only end up getting hospital-based AMR. You don't think about environmental AMR, and you're not able to integrate your antibiotic usage with your antimicrobial resistance patterns. Some of you know Dr. Swati, whose face is kind of blocked over there, but she's actually in this conference and she's one of the moderators for a session. But this was basically her work showing that ICMR guidelines and local antimicrobial resistance patterns are very, very different. So our hypothesis, the first hypothesis was that wastewater surveillance could provide community level hyperlocal insights, which could actually be used for practice and for policy. And these are on the left is basically this little map showing where all we tested the wastewater from both sewage treatment plants as well as from open drains. And the little pluses are where tertiary care hospitals are situated. And we have an integrated dashboard where we look at COVID, influenza, various types of influenza, A, B, H1N1, RSV, monkeypox, antimicrobial resistance, and hopefully NTD. And this is open to the public, and it's open and it's available on LinkedIn and on Twitter. We also found discrete hotspots of meropenem resistance, which is actually kind of scary because meropenem is a higher level antibiotic, usually given only in tertiary care settings, but we found meropenem resistance in open drains, which are supposed to be unconnected from hospitals. So where is this coming from? We don't know yet. This is what our dashboard looks like. It gives you zone-wise, bacteria-wise, and antibiotic-wise resistance. Our second hypothesis was that wastewater is a carrier of antimicrobial resistance. And for those of you who are from Karnataka, you'll be interested, or literally from pretty much any part of the world, you'll be interested to know that Bangalore is actually the world's second largest experiment in using treated wastewater to rejuvenate groundwater levels in districts around Bangalore. So something like 1,400 million liters of wastewater is being pumped from Bangalore to multiple areas around Bangalore. This obviously is amazing in terms of water, combating water scarcity, but it could be a problem when it comes to actually pumping out antimicrobial resistance or heavy metals or antibiotics and so on. What we find is that we don't find AMR bacteria, which is great, shows that our STPs are working, but we do find antibiotics. And one of the antibiotics we find consistently is isoniazid, which of course is a TB medication. I'm not going to talk about this again. I've already mentioned it. I do want to just kind of put this very messy picture is basically the consortium in Bangalore. You have people from the central government, state government, local government institutions, Indian NGOs, Indian for-profit companies, foreign NGOs, and you can imagine how complex, messy, and uncertain the whole process is, and it's filled with politics. But Despite that, we managed to get a couple of good things going on. One of the things that we realized, of course, is that the type of conversation matters. When you have conversations where everybody tends to agree with each other too much, then you have no sense making done. And then so conversations that elicit sort of real emotions are where sense making gets done. This is basically our sense making meeting with the BBMP, the local municipal government of Bangalore, and where we were able to actually integrate multiple lines of surveillance and come up with early warnings for COVID. I'm not going to talk about the scaling. We basically moved it to multiple cities. And finally, I would like to leave you with the key messages that wastewater surveillance has the potential to reduce biases in representation, can promote equitable mapping, not just of AMR, but of many other diseases. And you need collaboration for integration of data. So please join me, and I would like to acknowledge my partners. Thank you so much.
Any questions or comments?
What impact do you expect after you've done some work? If the government accepts cooperates with you, what do you hope to see?
Been trying to work with what I found is that very different governments have very different ways of working. So Bangalore government was extremely supportive in terms of COVID, but post-COVID, when the urgency has gone down, the rest of it, the antimicrobial resistance, the influenza, it's just like, okay, theek hai. Like, thanks for the information, but we don't really care about it. Lucknow government has been extremely proactive in saying we want to know all your data about all your diseases because we want to actually work on our public health systems to be able to be a little more proactive instead of reactive. The other governments, I think in Trichy and Trivandrum, they've been sort of so-so, but the Kerala government has now asked for a write-up to say, can this be integrated into the Kerala CDC? So hopefully that might actually move, I don't know. We'll see if that actually has any. But it does seem to be quite variable at this point.
Thank you.
Our next presenter is Dr. Martina Shalini AJ, presenting on estimating the social impact of peripheral health clinics in underserved urban and rural areas.
Good afternoon, everyone. Today I'm presenting our social return on investment analysis, where we try to estimate the social impact of two peripheral health clinics, one in an urban setting and one in a rural setting. So for some background, I'm from Bangalore Baptist Hospital, and we run several health centers and camps. Two of those, one in an urban center and one in a rural center, we included in the study. So we provide general consults, a dental center, specialty visits on a weekly or fortnightly basis, a pharmacy, and some lab services. And the aim of the study was to quantify the impact created by these activities during the financial year 2022 to 23. So the method we used is an evaluative retrospective social return on investment analysis. We used several methods for this. So there was a patient survey, multiple interviews with patients and stakeholders, 2 focus group discussions with staff, literature review. We also used our center records and accounts for estimating inputs. So for the methodology, we adhered to all the principles of the SROI methodology. The main one is to involve stakeholders to understand what changes, to value the things that matter, and to only include what is material. In the context of the SROI, materiality is defined by what is important enough to consider when making decisions on resource allocation. The other important things were not to overclaim, to be transparent, and to verify the result. So the steps of the SROI, the first one was to establish the scope and identify the stakeholders. This was done by the team doing the SROI. And once the stakeholders were identified, the second step, mapping outcomes, had 5 other steps. The first one was to create an impact map that said how the inputs translate into the impact that we wanted, identifying the inputs, valuing the inputs, identifying the outcomes, and describing them. The third step was to evidence the outcomes and give them a value. The fourth step was to establish the impact by removing the dead weight and the attribution, calculate the SROI, and then use the SROI in the decisions that were made. So for scope, we used the financial year 2022 to 23, and the stakeholders were identified, and the methods to include the stakeholders in the analysis was also decided. The inputs, for inputs, we took the center records and the accounts. Human resources, we took all the salary slips. We added the amount that was paid by the employer for EPF, medical benefits. For building capital, we included the rental values of the two centers as well as the annualized cost of the vehicles that we were using. For equipment, furniture also, we used the annualized value of the equipment in the two centers. Consumables, we digitalized the indenting registers and took the financial value. Overheads included everything else, electricity, water, biomedical waste, laundry, and CSST, which is the sterilization services, and the software that the center was using. So for the impact map, we developed a theory of change model, which included, which is also called a SODAT model. So it maps how the inputs and the activities that we do translate into an impact. So we listed all of the activities that are centered us, and we mapped out what we wanted. And from this, we took out the outcomes that we were going to use in the model. So this lists the outcomes that we finally decided on. The decision on the outcomes as well as the outcome indicators and the financial proxy was made using a literature review to identify the proxies. And then we used a focus group discussion to identify the ones that we were used in the final model. The return on investment itself, it was calculated for each outcome using the formula where the dead weight and the attribution were removed. We did not use drop-off since we did not estimate, we only estimated the present value for the year in which we calculated the return on investment. And the social return on investment that we ended up with was around 4.3 for both the centers. The urban center had a slightly higher return on investment. This is the individual outcomes and the dead weight and attribution that was used. So we used a dead weight of 30% for the clinic outcomes and 10% for the community outcomes. This attribution, we used a minimum attribution of 10% for savings in the costs and 30% for the others. For the outcomes that required more external resources, such as cataract surgery, refraction, and COPD treatment, we used higher attribution. We did a sensitivity analysis by varying each input and reduced all of the inputs for each outcome. So among the inputs, outcomes and financial value had, like, when they vary, they were the most sensitive. Among the outcomes, we identified refraction, provision of spectacles and refraction and provision of spectacles and provision of dental treatment as the most sensitive outcomes. So the L center and the urban area had a slightly higher SROI ratio compared to the rural center. This was mostly because of the higher utilization rate of services in the urban area. Among the input costs, the highest was for human resources, almost 76% was for human resources itself. And the sensitivity analysis showed that having more outcomes would give us a much higher return on investment. And among the outcomes, we found that provision of spectacles and provision of dental treatment had the highest return on investment. This was one because of the lack of similar services in the area. It was also because they directly translated into higher quality of life for the patient. So during the methodology, we took care to make sure that we provide a conservative estimate by keeping a dead weight and attribution. We did not, during our interviews with the stakeholders, which included the other service providers in the area, the pharmacies, we found there was no significant displacement, so we did not include displacement in the calculation. Among the limitations, there is a large degree of uncertainty in determining the attribution and dead weight, but we made sure to take a higher value during our discussions. The choice of the indicators and their financial proxies is subjective. But in spite of that, we kept including the stakeholders through interviews. This was the patients and the community leaders to ensure that the main outcomes, the material outcomes were included. So the estimated social return on investment for our centers was 4.3, and a minimum of 1.8 to 7.27 is the estimate. Social return on investment is a newer methodology, but it is holistic method to demonstrate value of money in social interventions, because there is no way right now to show impact. Thank you.
How your centers are selected, randomly selected, or you are deciding? Selection of the centers, primary health centers and urban centers.
These are the centers that we run. So while we have several centers, they usually run in collaboration with different NGOs. These two centers are completely run by us. So we had the cost data as well as the outcomes.
Your own center where you are working.
Yes.
Should have selected randomly. That will be some different data.
Any other questions or comments? Okay. Thank you, Martina. The next one.
Our next presenter is Dr. Ravi Prasad Varma, presenting on equity and justice for persons with disabilities in India.
Very good afternoon, respected chairpersons, dignitaries, friends. So recently, I was part of a consortium of researchers looking at local governments and health in Kerala. We concluded the study, and I think many of our papers are published in a supplement in the journal Public Health Action in the first part of the 2023. My areas of interest being palliative care, disability, rehabilitation. That was what I worked upon. And I draw from that experience when I am sharing some insights. We went across the whole state virtually because of the, initially because of the COVID pandemic, and then later we made a lot of visits also. So I draw upon that experience when I'm reflecting on our approach to disability here. So I'll talk about the problem statement very briefly, and the standard approach, which is something we've been hearing from quite a lot in the morning, and some new perspectives that Kerala had in a way attempted, and some things that have worked, and what probably this means for me and others like me as a researcher in this area. So Kerala conducted a disability census in 2015, where the prevalence of disability was 2.32%. The 76th round of the National Sample Survey reported a slightly higher prevalence of disability. Now, the entitlements of persons with disabilities, we have the Rights of Persons with Disabilities Act 2016. We have other gazette notifications and other things which determine how we address disability. Today morning, we heard about, sickle cell anemia not being certified as a disability because it doesn't have 40% disability, something like that. There's a reason for that. It's not exactly the problem of the panel there. There is a gazette notification which says, so if I can hold my neck up, but I am paralyzed everywhere else, my level of disability is 60%. It can't go above 60% if I can control my neck and look this way and that. So disability is defined, and the percentage is defined in a, I think largely outside the medical system, mainly by the social justice, for the purpose of giving somebody a certain level and deciding on the benefits that they are eligible for. So the standard approach is this form of documentation and some affirmative action in terms of job reservations, financial benefits, and so on. Okay. But it's very, very difficult to get these. We listen to ever so many stories about a person with disability going to attend an examination for disabled persons and finding that the exam was on the first floor. So we heard so many stories like that, and getting a certificate can be extremely difficult. So that again very cumbersome. So it's a very difficult process now. To some extent in Kerala with decentralization, there has been a move for much of this documentation that can happen at your own panchayat. So in that way, some benefits are there. And then with the IT kind of services that are getting expanded more and more, you have customer service kiosks which are available nearby, where you don't have to go to the district headquarters again to get your certification. So when Kerala decentralized, some of the social welfare functions did mention disability, but as setting up centers for the care. So it's like these are people who need to be cared for. The perspective started changing in about 2 decades, where we are talking about their voice and their participation. So we are very good at writing beautiful policies, program guidelines. Okay. And they can be used as textbooks. I'm not joking. Some of the policies and programs written in Kerala can be used as textbooks. But implementation is a different story. So a very senior retired bureaucrat who was helping us with the study said that in Kerala, if it's there on paper, it is considered done. So you get what I'm trying to say there. Okay, but we have made several attempts there. So we are moving from this kind of giving services to participating, listening to them and taking them along with us. So one approach is the Bhinna Sheshi Grama Sabha. Kerala has this Grama Sabha approach where at least 3 has to be done every year. We have the Janakiya Sutranam, people's planning campaign, where plans for each local governments. Local governments in Kerala receive about 25 to 30% of plan funds. When the plan funds reach the state, they are given straight to the local government department. So the planning for that has to happen at the Grama Sabha. So they are very, very important in Kerala. And there should be special Grama Sabha for the disabled or differently abled. Pardon my language if I'm not using something that's okay with everyone. Okay. So the Bhinaseshi Grama Sabhas we attended, we couldn't find many persons with disabilities there. Only those with certain mild disabilities could attend, because this is notified at just 1 or 2 days notice. And when you look at somebody with a wheelchair, what that person said is that, I'm not like you. You can go out of your house and then think, maybe I did not turn off the gas, come back and check. This person cannot do that. This person has to prepare on the previous day for the vehicle, for the person to shift from the house to the auto rickshaw and hold the wheelchair and keep it there. And they plan to cover 5 or 6 places in one visit. They can't come back, go, come back again. So for them, travel is a very, very well thought about and prepared activity. So we can't say tomorrow there is Grama Sabha, please come. So that's how it is done, and it doesn't work the way it should do. But not everything is that bad. So I'll just share another small story and then say there are many more. I can't share everything at this small point. But one thing that particularly motivated us was the BUDS institutions. BUDS is not an acronym. In 2004, there was a survey for poverty alleviation, and they found that poverty is most in families with disability. And with no precedence, the Panchayat started an institution for persons with disability, children with disability from very poor households. Okay, and when it started, the first one in Bengaluru in 2004, and I'm just sharing the story in Mattanur in 2023. That is closer here, and it's in Kannur district. We have now about 300 BUDS institutions in the state. All of them sustained and remained functioning through COVID. And this is from Mattanur. The Mattanur BUDS school children performed, their band performed at the Republic Day parade in on January 26th, and their dance team is also very, very, very famous and performing on a lot of venues. Yeah. So from a situation of abject poverty, neglect and stigma, we've reached some situation where things can happen. Okay, so there is promise. And so we need to move from a kind of welfare, let's give something for them. From that to see what they can do and what we can do to help them do what they can achieve based on the sense and Nussbaum's capability framework. Thank you.
Our next presenter is Dr. Roshine Mary Koshy, presenting on equity in healthcare, a goal and a journey.
Morning, everyone. I'm a physician, a family physician, and a researcher. I worked for a year in the Palamu district of Jharkhand in a 75-bedded hospital, and then for the last 9 years in a growing secondary level care hospital in Karimganj district of Assam. I'm presenting this paper as a viewpoint based on my observations and experiences, and I've titled it Equity in Healthcare, a Goal and a Journey. The term equity is best appreciated in how it differs from equality. Whereas equality means providing the same to all, equity acknowledges the reality that we do not all start from the same place, and hence our journeys to reach the goal will need to accommodate this reality. Next slide. Okay. Setting equity as a goal in the healthcare space requires not only the acknowledgement that inequity exists, but also an estimation of the degrees of inequity, so that the progress in achieving equity or its lack thereof can be tracked. The image that is displayed on the screen is taken from an article in 2017 titled Nations Within a Nation. It aimed to estimate the disease burden and risk factors in every state of India as part of the Global Burden of Disease study in 2016. The top map shows the variations in disease burden in the 1990s. And you can see that the dark red states, those are the states which have a high burden of communicable diseases, maternal and neonatal deaths, and disorders due to nutrition. The picture below is the scenario 25 years down the line, 2016. The burden of illness has dropped by around a third in India, but the same states, which are now in light blue, they still lead in the disease burden of all the disease entities that I mentioned. This article helps to frame the issue of inequity in healthcare over time, and it helps to objectify it so that health policies can be tailored as per the needs of the population groups which are affected disproportionately. At a conceptual level, setting equity as a goal starts with identifying the most vulnerable families in a community and a population with respect to healthcare. In the last 2 years, I have been part of a team which has been trying to fill this gap in knowledge in the domain of maternal and neonatal health. The hospital that I'm a part of in Assam has been rendering valuable secondary level healthcare at affordable cost to rural Northeast India. You can see in the table the MMR of India, as per the sample registration system, 2016 to 18 is 113. Assam has the highest among the states of 215. As part of a research collaboration, we have done a demographic systemic surveillance in Lower Poor block. That's the block where our hospital is situated. The map on the left shows the block with a catchment population of 1.5 lakhs across 121 villages, which are divided into 5 geographical clusters, and the hospital is in cluster 2. And what is displayed on the table is an interim result of a baseline survey which is being completed. I have to caution that it only reflects a cross-sectional time period in 2019-20, but I'm using it to illustrate the issue of inequity which plagues healthcare in our country. The interim data shows that the maternal mortality ratio in Lower Poor block is 366, more than the state average. But what is heartbreaking is that there were regions in the block, which I've highlighted as red arrows, which had MMRs which were similar to African countries like Sierra Leone and Somalia. These are also the regions in the block with the largest proportion of the tea garden communities in Assam. These are a community in Assam which has a host of systemic hurdles to cross in order to receive quality healthcare. And these hurdles include, but are not limited to, poor social support, a very exploitative labor system, and a lack of tailored healthcare delivery systems. What makes healthcare affordable, accessible, of optimal quality, and contextually appropriate. Who defines these terms? Identifying and defining these critical ingredients, respecting and incorporating the perspectives of various stakeholders is foundational to developing sustainable models of care. I think we also need to acknowledge that these definitions themselves are dynamic. What holds true in the past may not hold true in the future for the same community. But what is being emphasized is that context and stakeholder perspectives should be central to the journey towards equity. Equitable healthcare needs to be achieved in a complex adaptive system. The picture on the right shows how an urban healthcare space in Bangladesh can be constructed and viewed as a complex adaptive system. I'm just briefly stating some of the characteristics of a complex adaptive system. When we look at healthcare space, it's a complex network, a lot of subsystems, various roles, various identities, a lot of interactions between the subsystems, various degrees of interactions, and also the fact that it is an adaptive system. Whatever change happens, either internal to a health system or external, affects it, but the health system will find multiple states of equilibrium through either a positive feedback loop or a negative feedback loop. And these states of equilibrium might be healthy or unhealthy. So what is the implication of approaching healthcare space as a complex adaptive system and with equity as a health goal? The first is that vulnerable and marginalized communities have to be the cornerstone and the starting point of the journey towards equitable healthcare. They cannot be the afterthought and they cannot be a collateral gain. Hence, deep connections with the communities that we're serving is foundational. Second, in a dynamic healthcare system where much is out of our control, stability is critical. So stable healthcare platforms, however few or small, will promote and sustain achievements made towards equitable healthcare. The fact that a healthcare system is dynamic also means that there are very complex cause-effect relationships within systems, and these are not always linear. At a practical level, it means that any intervention that we do in a healthcare space can have surprising outcomes and unintended consequences. In this journey towards equitable healthcare, we need to anticipate and address unintended harmful consequences, either to the communities that we are serving or to the healthcare delivery platforms. The fact that there is so much of interactions between subsystems means it opens up the opportunities for us to bridge different disciplines, different types of knowledge, and leverage interactions across scales to create synergy to ensure sustainability. I'd like to conclude by stating that the goal of equitable healthcare is upstream, and the journey requires rowing against the tide. At an individual level and at a systems level, it requires a visionary mindset, an openness to learn, unlearn, relearn, reflect, and a flexibility to adapt our journeys and to leverage the opportunities that arise in different seasons. Equally crucial is reaching the goal in a timely manner. Momentum is vital, and every little effort at every level counts. Thank you for your patient listening.
Okay. Thank you. Thank you, Roshine.
Our next presenter is Dr. Suchetana Ghosh, presenting on structural violence and well-being, a case study of women in prostitution at Kolkata.
Good afternoon to everybody present here. I would like to thank the organizing committee of the conference for giving me the opportunity to present my paper. And it is a privilege to be here, undoubtedly. My paper is titled Structural Violence and Wellbeing, a case study of women in prostitution at Kolkata. I'm not from medical background, as you can see. Though I have a public health, social work, I'm a social scientist with a public health, with a touch of public health. The first question arises is that, can women in prostitution be violated? Now, it is generally, STDs, women in prostitution are generally associated with STIs, STDs, HIV and AIDS, But the structural systematic violence, sexual violence, covert and overt physical, non-physical violence on the well-being of the women in prostitution are less explored a phenomenon. In fact, the stereotypical patriarchal biases or the sexism belief that women in prostitution are paid to be violated. They are there to be violated. So like all other occupations, good health, we forget that like all other occupation, good health is crucial for the women in prostitution, as ill health can lead to loss of income and customers incurring expenditures on treatment, leading to indebtedness. These factors lead to further ill health due to overwork and inadequate nourishment as they attempt to recover their financial situations. In such a context of inequality, the paper ventures to explore some narratives of violence in the lives of women in prostitution in red-light areas of Calcutta, now called Kolkata. And these three areas are Sonagachi, Bobazar, and Kalighat. And how such cases have deep impacts on the well-being of women in prostitution. The objectives are to develop a framework for understanding the construct of violence in the context of prostitution, to identify the nature of violence faced by the women in prostitution, to identify the individuals or agencies inflicting violence on WIP, taking the specific context of RLAs of Kolkata, to understand the impacts of such violence leading to inequity, stigmatization, and marginalization of these women, to get a sense of WIP's perspective or their perceptions of livelihood and well-being. The paper is based on my MPhil dissertation titled Interpreting Prostitution, Violence Commodified, which was a work on the nature, type, cause, source, and impact of violence on health of women in prostitution at Kolkata. And qualitative methods of primary data collection included convenience sampling, focused interview, a combination of non-participant and non-controlled observation, informal group discussions, and case studies. Now, to begin with, why violence? Why masculine has to be, or masculinity has to be patriarchal? Why passion has to be transformed into violence? Why sexuality has to be based on thanatos, meaning death and destruction, instead of erotica or eros, meaning love and pleasure, especially in the context of prostitution. Now, to understand this kind of question, to respond to this kind of question, various scholars, social scientists, they have tried, theoreticians, they have tried to answer such questions. To name a few, I won't get into the detail of it because in itself it can be a paper. So I would rather name a few, such as Sigmund Freud, and along with psychoanalytic school of feminism, Simone de Beauvoir, existential school of feminism, radical feminists, and say Kate Millett. All these people, they have tried to understand the violence, especially in the context of prostitution and sexuality of women's, as far as treating women's bodies. Now, thereby prostitution as a sexual commodity, where the revelation of gender politics is most obvious, certainly occupies an important place in these schools of thoughts. It's not. So patriarchy as rule of the fathers, as such superiority of male, instructing male to be domineering, masculine, and women to be dominated as feminine, where the mode of dominance is mostly an androcentric force leading to violence. Foucault also has discussed about all these issues, and Foucault was really obsessed with power and sexuality. It comes in various work done by him, especially the History of Sexuality, Volume 2. While talking about the violence of that, Foucault says that sexual act in itself is violence. So German Greer also made related statements in her work, in the female Una. In extreme cases, it takes the form of loathing, disgust, she says, occasioned by sadism, fastidiousness, and guilt, and inspires hideous crimes on the bodies of women, while German Greer talks of sexuality and sexual love. Now, in a study on rape, Susan Brown-Miller argues that rape is nothing more or less than a conscious process of intimidation by which all men keep all women in a state of fear. Now, there are different scholars. In reverse realities, for example, Naila Kabir, who is an economist, she basically pointed out the economical side that of the vulnerabilities, sexual vulnerabilities of women, like vulnerability to sexual harassment and domestic violence is an aspect of gendered nature of poverty, because poor women especially are most exposed to the risk of harassment and least able to remove themselves from such situations. Therefore, violence done with has a strong economic and gender foundation as well. It dehumanizes the woman's body, alienating from all human elements, and then it could be violated much more easily, especially in the context of prostitution. Now, I would say that prostitution in West Bengal has to be analyzed in the socioeconomic background of high poverty levels, disproportionately more in rural West Bengal, low status of female indicated by lower literacy levels and low value given to their labor, possibly increasing feminization of poverty and increasing cases of reported violence against women. Now, I'm not getting into these charts. They are showing that the rate of violence, the kind of incidence of violence against women in West Bengal, and West Bengal in all India statistic, their status in trafficking and buying girls and selling girls. Now, this is the context of rural-urban poverty. We see that rural poverty is decreasing, but not as fast as urban poverty. We see male-female literacy rate and work participation rate, where male work participation rate is, literacy rate is little higher, but female work participation rate has increased, but not in comparison to female literacy rate, because female literacy rate is much higher. So then who is participating in the work process? So I will now directly get into the findings. The findings first regarding the place of origin and literacy level. Of 24 case studies I have done, 15 prostitutes came from rural areas of villages, 2 from semi-urban towns, 2 from Kolkata itself, and 5 from other states, inclusive Bangladesh. 21 of 24 are literate. Total number of family members and their occupations, majority are from a family more than 5 or 7 members, whereas the earning members are either mostly jobless, retired, not capable of work, or they are small farmers. Now, there are various reasons for coming into prostitution, like poverty, domestic violence, sexual violence, joblessness, sold or delivered by a third party, family members already in prostitution, death or disability of the earning members, shift from other occupation, and so on. Violence that is inflicted to terrorize the prostitutes can be categorized as covert and overt violence, such as psychological, economic, and social, and physical, sexual, verbal, and clinical. The 6 of 24 women are the ones who periodization of violence, who some of them faced violence before entering the sex trade, some faced violence after entering the sex trade, but 11 came under the category who combines both. The agencies inflicting violence on the women in prostitution are babu, husband, employers, client, marital, paternal families, landlady, traffickers, colleagues, police, and so on. But however, most of them face a combined experience of violence from all these agencies. 9 of 24 prostitutes work independently. Now there is a category of adhyara who gets the half of the share, chokris, and then there are independent prostitutes. I won't get into the detail now, but there are a lot of economic violence happening in these categories because of due to the economic exploitation that they face. The economic and financial transaction with the family members, most of them support their families back home, rural villages, and sometimes they also support the babus, or some of these babus are permanent boyfriends or husbands, they call them husbands, or sometimes they have run away with the prostitutes' money. Such cases are there. Now, findings, children's residential status. prostitutes children suffer, though they stay with, some of them stay with their mothers, some of them are sent back to the villages, but they suffer from social and psychological stigmatization, though the mothers within their limited economic reach try to provide the best for their children. General health problems of the prostitutes. Now, I would say the health problems are generating from the basically the kind of situation they are living in, which are mainly due to poverty. The majority suffer from fever, gastric ulcer, head and stomach ache, while some others suffer from malaria, diarrhea, anemia, and so on. The health services they avail are, according to the importance, public health hospitals, NGO health centers, and private clinics and dispensaries. Prostitutes, now I would leave you with the tomorrow, that prostitutes do not really seem to visualize their aim in the operation itself.
Dr. Ghosh, sorry to interrupt. I think you must finish in the next minute.
And well, most of them do not think that legalization will end their misery. Thank you.
If there are no further questions, we'll move on to our next presenter, Dr. Philip Finney, presenting on estimating glucocorticoid misuse as a surrogate marker of health disparity across different regions in India.
Good afternoon, friends. I deem it a privilege to share a part of my journey in the last 10 years, doing small research projects, observational studies on the problem of steroid misuse across 2 parts of India where I worked in. We all know about steroid misuse, but this issue still remains inadequately addressed, unlike antimicrobial misuse is well known and people talk about it. It is in the first year of medical school, Professor P. Zachariah warned us as young medical students that steroids are wonderful medication in the short term, but can wreak havoc in the long term. My training in endocrinology here at Velo taught me how to identify the rare and the esoteric causes of Cushing's syndrome, the endogenous Cushing's, but did not teach me enough about the public health impact of what steroids can do when used indiscriminately, even though we all know the statistics that more than 90% of Cushing's syndrome is iatrogenic. There is no nationwide scientific literature on the magnitude of this preventable issue in India, is what we discovered when we did some literature search. This is the context in which I worked between 2008 to 2017 at the Duncan Hospital in Bihar, Roxol, where this is a good secondary level hospital, but a few kilometers from the hospital, this is where the majority of our patients came from a very poor setting. This picture was sent to me by my colleague in Roxol last year of a baby who was not thriving well and now looks like this, and the parents were giving medications for this child, a syrup for making the child look healthy. And this is happening in 2023. And we all know, without saying it, this is iatrogenic Cushing's. The realities in northern Bihar and UP, where I have traveled extensively and even sat in compounder clinics, is that 80% of our patients are treated by compounders and quacks. Oral betamethasone and dexamethasone are present in many prescriptions given to the patients. And my teacher here in medicine, Dr. Alka, used to tell me, and it became more real to me, that always assume people with asthma, arthritis, or skin diseases are on steroids till otherwise proven. And many people used to come to our emergency, and I was a physician covering on-calls almost every other day. And I used to see people with unexplained hyponatremia, hypotension, and Addisonian crisis. And we wondered why. Many of them were actually people on steroids who had become ill and didn't have the top-up to continue taking the steroids for their chronic illness. And we faced significant morbidity and mortality. In 2012, one of our pediatricians who's trained here was my family medicine resident there. He suggested, sir, why don't we look at this problem of steroid misuse and see if we can document this problem. And this, in collaboration with Velo, we did a study on hospital incidence of iatrogenic Cushing's at the Duncan Hospital. And this was published in the Tropical Doctor, along with Dr. Nihal, who's here. Basically, we identified 22 people who had been abusing steroids over a 6-month period. The bulk of them had overt features of iatrogenic Cushing's, but small proportion of them actually had come with an Addisonian crisis to the emergency room. And when we screened them for the clinical evidence of Cushing's, we found that majority of them had osteoporotic fractures unrecognized when we screened them with X-rays, as well as many of them had recent onset diabetes, hypertension, and cataracts. And the figures are self-explanatory, which is put up here. The key information gathered is that nearly 2/3 of our patients had been taking the steroids for a chronic arthritis. 1/4 of the patients were taking it for a chronic respiratory illness, and a small proportion for a chronic eczema. And 90% of these 22 patients had been taking it for more than 1 year continuously. I'm just giving you snapshots of the 5 studies we have done, so I don't have time. We can discuss it later. This led my family community physician who was trained here, Dr. Sharon Cynthia, to look at this problem from a community perspective. And what she discovered was shocking. We did a two-stage sampling method to interview 240 households in the period from April to May 2013. Anybody who had been sick in the last 6 months, we tried to look at their prescriptions. And we found that of the 334 patients who had been sick and required medicines who had prescriptions, 1/3 of them had been using glucocorticoids for a significant duration of time. And when we did the mathematical calculations, we found that nearly 1 in 15 persons in the Roxol block would potentially have a suppressed hypothalamo-pituitary adrenal axis because they've been overusing steroids beyond the duration of 3 weeks at supraphysiological doses. That led us to comment that it's not enough to publish this only in our scientific journals like the Tropical Doctor. We need to rock light the lay media where people will see. And this is a publication in the Telegraph newspaper where Dr. Anand Zak was instrumental in sending one of these journalists to interview us. And she put it up in the Telegraph, which is a well-respected paper in Eastern India. But our current generation of medical students and many of our students don't read newspapers. Is a problem, is also an issue. So we realized we need to get into the electronic media. And this is a journalist who wrote this paper up in the electronic media in a catchy way about steroid misuse behind many chronic diseases in Bihar town. Last year, this was published again by my colleague. A team of 5 of us sat together and looked at what are the causes of death in Bihar. Are they all just due to cardiovascular disease, or is there something else? So we used the verbal autopsy model, which was alluded to a few hours ago by one of my colleagues here, Sharon and myself and Dr. Santosh and a few of us looked at the verbal autopsies in that region to see what are the causes of death in the community. This is 253 verbal autopsies collected over a 1-year period in the East Champaran district. Only 7% of people who die in that region have a death certificate. So you can understand what is the magnitude. We don't even know what's happening. But from the limited information we have, we realize that COPD is actually the biggest killer of deaths in our population. And at least 6 of these deaths, when two physicians independently evaluated the histories taken by our health workers of the history, we found that at least 6 could potentially have had glucocorticoid misuse and abrupt stopping implicated in their deaths. So what to do about this problem? We have been generating evidence, but is that enough? We realized I had to move down to Kerala for various family needs. And that's when I joined in Tiruvalla and Believers, we said, why don't we look at the problem in an affluent state of Kerala? We went to the rural communities in Koni district, in Pathanamthitta district of Kerala, and we looked at the glucocorticoid use and misuse using the identical methodology used by Sharon in Bihar. And what we found here, we interviewed about 1,730 individuals in 450 households. We used the same last 6 months. If anybody had been sick, we tried to get their prescriptions and analyze their prescriptions and talk to them to find out how many of them had been using steroids. We found that, of course, it was much less. Only 2% of the population had used steroid for some duration of time. And we found that when we calculate the mathematical model, there are about 2 lakh people in Kerala also who potentially can be having a suppressed hypothalamo-pituitary axis. This led us to do the difficult task of interviewing pharmacies, which many of them were reluctant to share information. So we worked out a surrogate way of finding out how much is the magnitude of steroid misuse by interviewing all the pharmacies in the Tiruvalla municipality. And we found what proportion of their sales was from steroids. And we realized that most of the pharmacies, their sales was less than 2% of their sales was steroids. But we found 5 to 6 pharmacies, including one where more than 10% of their income is from sale of glucocorticoids using a robust community health methodology. And many of the pharmacists did not know about the knowledge of why steroids are being given. And 60% of them didn't know about any of the adverse effects of glucocorticoids in a state like Kerala. So this generated a discussion in the editorial in the Indian Journal of Endocrinology and Metabolism, which is our apex journal, saying that this is a big problem. And now in the current national conference, we are having steroid stewardship being discussed in this coming conference this month. So we have tried our best to generate some evidence. So how do you proceed further? We need to generate more evidence, get into advocacy, and try and see if we can influence drug regulators and healthcare policies. So I want to conclude by saying that steroid misuse exists even in Kerala, but perhaps not to the extent in Bihar. cheaper oral drugs are widely used in North India. Prescriptions are most often from unlicensed practitioners. In Kerala, we found a lot of people use inhaled corticosteroids, but in our studies in Bihar, we found hardly anybody uses inhaled corticosteroids for asthma or COPD. And perhaps the usage of inhaled versus oral is another surrogate marker of poverty and health disparity between these two states. I want to conclude with this and thank you once again for your patient listening.
Yeah. Thank you, Philip. Yeah, any quick questions?
I got one patient with quadriparesis, and he was consuming gym tonic. Gym tonic is Dexona plus cyproheptadine. Cyproheptadine added as a serotonin antagonist, which prevent the appearance of Cushing syndrome.
Is Dr. Martina in the audience? There's a question which came up after you had finished. So if the question is, can you explain dead weight and attribution to a lay audience in about 60 seconds?
Okay, so dead weight is the proportion of the outcome that would have happened if our intervention was not there. So it is what would have anyway happened, even if we were not there, we had not intervened and the center didn't exist. Attribution is the proportion that even when we intervene, we attribute to other things. So like when we give a treatment, the impact is not entirely due to the treatment. It is like the patient has to take the medicine or maybe someone else has to do something. So for example, like the cataract intervention, even though we do the selection of patient, the medical clearance, the actual treatment happens somewhere else, like the surgery happens somewhere else. So there's a higher attribution removed from the impact that we cause.
Thanks. So any comments, Dr. Prabir, overall? You want to make a couple of remarks?
Overall remarks. No, they were very good presentations. I think everybody, in my estimation, has got nice marks, but we didn't get that many questions. So those who contributed questions, many thanks, because we improved the marks of the people you asked questions to. Unfortunately, that means you may have cut on your own marks. And yeah, we were sorry that some people couldn't finish, so you must plan your things so that you finish on time. Nice that we had at least one non-medical presenter. This has been one question that's been raised already on Twitter. We have a seminar on equity and very few non-doctors. So we had one non-doctor among the 8 presentations. Thank you for having a non-doctor presenter. Happens to be from my area. I must be introduced now. Okay, thanks to everybody. I think there has been a feast, lot of high theory. I hope you go back and read the presentations when you get them. Some of the theory was really deep, I think, for the medical people. Dworkin and Rawls and then German Greer and lots of things that doctors have not heard about before. So this is the time to start reading.